Good morning, everyone. We're starting our session right now. First, I would like to thank you very much for joining us today for this important ICASA special session on criminal justice reform and health and HIV in prison settings in Africa. First, I would like to thank you very much for joining us today. And also would like to thank the distinguished speakers. We have a very good panelists for the session today. We have Nigeria, South Africa, Penal Reform International, and also, last but not least, the host country of Zimbabwe, is Dr. Gagalini, who is us today. Well, I would also like to thank the co-chair, Dr. Sieber, for joining us today. The topic is very important, and I want to clarify that since the beginning of the HIV epidemic, people in prison, as one of the key populations, have been systematically left behind for different reasons in many countries, not only in Africa, but other continents as well. And I can see that while we are making progress in achieving our 2025 targets and 2030 targets of ending AIDS as a public health threat, I think we need to do more to reach the equity and equality for key populations, and including people living and working in prison settings as well. However, yes, we have done so many work when it comes to HIV testing, treatment, reducing stigma and discrimination. However, there is other factors
HIV response. When we go into settings such as UNAIDS Program Coordinating Board, or looking at things around the Global Fund, and doing all of the new funding model applications, we need to be thinking of prisoners. We need to be thinking of those incarcerated and how they need their HIV prevention and care and treatment services to be retained while incarcerated as well. The funding, the services, the navigation all needs to be thought about when thinking of the future of the global HIV response. As Ihab mentioned, as we near closer to the 2025 and the 2030 goals, We also got to think about the 10-10-10. Stigma discrimination around those that are incarcerated is one of the most, I would say, prominent reasons why we don't see any funding or very low levels of funding going towards prisoners as a population, especially as a key population. So as I close and hand it back over to Ihab, I want to really make it a point that we have to center prisoners and those incarcerated in our global HIV response, in our country response, regionally, and we have to continue to be a voice for those that don't have a voice that are incarcerated at this current time. Thank you so much, and thank you for being here.
Great, thank you very much, Cedric, for this inspiring opening remarks. I thank you for that. And now we move to our first speaker, and today we have Dr. Helen from Nigeria Correctional Service. Thank you for joining us. Dr. Helen, she is working for the Nigeria Correctional. She's assistant controller, and she's the manager for HIV programs and responding for all the HIV programs in correction facilities in Nigeria. Thanks for joining us, and the floor is yours.
Good morning, everyone. Thank you, Ihab, and the co-chair. I want to thank everyone for coming to attend this session. I count it a very wonderful privilege for us to be here as a key population prison focus. I am Helen Apanama, the Assistant Controller General of Corrections in Nigeria, HIV/AIDS Program Manager. I'm presenting, promoting the criminal justice system reforms and prison health system reforms. What's criminal justice system? Criminal justice system is a network of governmental and non-governmental agencies that are vested with the responsibility of managing those that are in conflict with the law. It is a multi-related, interrelated components comprising the law enforcement, prosecution, the judiciary, and the prisons or corrections, depending on what your country addresses the prisoners. That specific duty and efficient criminal justice system should be able to adjudicate, investigate criminal offenses efficiently and impartially, while considering the human rights or the rights of the offenders, the rights of the victims, and the rights of the larger community. But what do you see? In Africa, the criminal justice system is not as effective as it should be. There is a vicious cycle of a slow response. And why is that? Because studies have found out that there is no national strategy to providing primary justice as there is for primary health. And that's why Next slide, please. Because of all those backlog of processes, delays in prosecution, there are a lot of issues. The issues arise from overcrowding, with intending consequence of overcrowding. We have a lot of disease burden, disease prevalences from HIV/AIDS, tuberculosis, STIs, and other conditions in the correctional system. Next slide, please. Like the chair introduced, the burden of HIV within the correctional system, within the prison system, is so high. It ranges from 2.3% to 34.9%, depending on the region. Looking at this, you can see the highest war prevalence in Africa, Botswana, Zambia, and the little record of 2.8% prevalence of Nigeria is still higher than the national prevalence of 1.4%. And this is because of the inefficiency in the criminal justice system. Next slide, please. We're still talking about the effect of inefficiency in the criminal justice system, which results in overcrowding. And this overcrowding has put people in the correctional service, in the correctional centers, the inmates, the personnel at a higher risk of communicable and chronic diseases, mental illness, substance use, self-harm. Next slide, please. So what are the challenges of the criminal system, justice system in Africa? The most of it is the high rate of pretrial detention. Of the 1/3 of global prisoners population, 40% global prisoners population of awaiting trials, 40% are within Africa. And out of that, 50% are in Central and West Africa. That is the burden of pretrial detention. To explain why it is as high as that, Africans would like the trials in courts, even on a very, very excusable and flimsy excuses. We tend to rush to the courts, and that's why we are having the high rate of pretrial detention. Aside corruption in the system, the poor institutional coordination, knowing the criminal justice system, we have other agencies. One might be a clock in the wheel of the system to work. There is slow dispensation of justice, poor access to justice. These are challenges of the criminal justice system, and these impact the health of the prisons and prison community. Next slide, please. So I have to run. This is the Mandela rule. That is a prison healthcare system in Africa. We are supposed to follow systematically and completely the main Mandela recommendation for the treatment of healthcare. It's without discrimination. Government responsibility, offering service free of charge. The prison health system in Africa has some form of health promotion, treatment of disease conditions, and prevention of infections, but the capacity is effective. Let's go to the challenges, because I've been one of time. Challenges of the prison healthcare system in Africa. Next slide. What are the challenges? Next slide. These are the challenges of the prison health system in Africa. We have issues with nutrition. We have issues with health professionals. We have inadequate supplies, inadequate capacity building. These are the challenges of which reforms must be built around. Next slide. The prison health reforms in Africa is a bedrock of quality health service provision and public health care, bringing equity to the people in the prisons, the prison inmates. And then the reforms have to be built around the provision of healthcare infrastructure, like we saw in the chat before, to improve the conditions. Collaborations, we need a lot of collaboration to achieve and attain the goal of reaching and eliminating inequity within the prison health system. Thank you.
For this very informative presentation. I think we have diversity of speakers in this session, so keep your questions. We hope that we have a few minutes at the end of the session for questions and answers. Our next speaker is joining us online, and we have Dr. Rory. Dr. Rory is joining us from South Africa, and she will share with us some insights in this topic from South Africa Correctional Facilities. She is the Director of HIV/AIDS and the Chief Directorate Healthcare Services, Department of Correctional Facilities in South Africa. Dr. Rory, thank you very much, and also great to see you online. The floor is yours. Unfortunately, we cannot hear you for technical issues.
Pardon me, my microphone was closed. Greetings to all on the virtual platform as well as those
Dr.
that are
Rory,
in
do you hear
attendance.
me?
Can you hear me?
No.
Can you hear me?
Now, yes, please. Go ahead. We can hear you now. Please go
Can
ahead
you
from
hear
the
me?
beginning. Sorry.
Can you hear me?
Yes, we can.
Thank you very much.
Thank you very much.
Greetings to all in
Greetings to all in
attendance. I'm getting feedback,
I'm
but
getting
I will going
feedback,
to
but
try my best to
I'm
speak.
going to try my best to speak.
I think let me pass the
Let
greetings and
me
zoom into
pass
the
the greetings
presentation.
and zoom into the
I will
presentation.
be presenting on
I will
behalf of the
present
Department of
on
Correctional
behalf of the
Services,
Department of
South
Correctional
Africa.
Services, South
I will
Africa.
request that we move
I will
straight
request
to
that we
the
move
slide
straight to the
relating to the
slides
purpose. We'll skip the
related
first two
to
slides.
the first two slides.
Can skip. Thank you very much.
Yes, thank you
So
very
the
much.
purpose of this
So the
presentation
purpose of this presentation
is briefly just to
is briefly
give an
just
overview
to
about the
give an
practices
overview about the
and
practices
experiences
and
on health and
experiences
HIV
on
in the
health and
Department of
HIV in the
Correctional
Department
Services.
of Correctional
Next slide.
Services. Next slide.
So the South African
So
Department
South
of Correctional
African
Services has got
services
6 regions.
has got 6 regions.
You will note that
You will
in
that
South Africa
in
we have
South
9
Africa we
provinces,
have 9
but
provinces,
as a Department of
but as a
Correctional Services, we have
correctional services,
lumped
we have
together some of the
lumped
provinces,
together some of
and
the
hence we
provinces,
only have
and hence we only have
regions.
the 6
Now the 6
regions.
regions further culminate
Now,
down
the
into 46
will
management
culminate down
areas,
into 46
and
management
these
areas,
management areas
and
equals
these management
districts.
areas equals
And then
districts.
in these management
And then
areas, we have about
we have
238
about
correctional
238
facilities.
correctional
Next slide.
facilities. Next slide.
Just to shortly say,
Just
this is the vision of the
shortly say this
department to
is the
provide
vision of
the
the
best
department to
correctional
provide the
services
best
for a
correctional
safer South
services
Africa
for a safer South
with a
Africa,
mission of
with a
contributing to a
mission of
just and
contributing
peaceful
to a just and
South
peaceful
Africa through
South
effective and
Africa
humane
through effective and
incarceration of
humane
inmates. Next
incarceration
slide.
of inmates. Next slide.
Beneficiaries of the healthcare programs rendered in the South African correctional centers are inmates, and when we say inmates, we refer to both sentenced offenders as well as remand detainees and the babies that are there with their incarcerated mothers. Services that are provided are equally provided to both males and females, except in instances where the services are gender specific. Next slide. Those are the mandates that governs healthcare delivery within the Department of Health. I heard the previous speaker referring to the United Nations Standard Minimum Rules and all the others that are listed below. I'm not going to go into detail with those for saving time. Next slide. So as a department, we have really come a long way in terms of the development of policies to provide guidance of how health and other programs are rendered within the Department of Correctional Services. We do have a healthcare services policy inclusive of HIV and AIDS issues. We have a pharmaceutical services policy, nutrition, medical parole, a policy for the control of tobacco and smoking in correctional centers. And then in terms of the strategies for HIV and AIDS that we are implementing, we are in alignment with the National Strategic Plan for HIV, TB, and STIs. And when it comes to the implementation of infection prevention and control, we align with the National Infection Prevention and Control Framework of the Department of Health. Chairperson, I hope I'm still audible. Chair? Am I audible? Am I audible, Chair?
Rodin, we hear you very well. Please go ahead.
Thank you. Thank you very much. We can then move to the next slide. When we look at healthcare facilities within the department, you will note that as a department, we are mandated by the Department of Health to render a comprehensive primary healthcare package. And this primary healthcare package is rendered in all the 238 facilities nationally on a 24-hour basis. Where inmates require secondary and tertiary care, we do refer to the facilities of the Department of Health. We also have internally 37 pharmacies that are registered with the South African Pharmacy Council, and we have 227 food service units. Next slide. When we look at the services that we render, looking at HIV and AIDS prevention specifically, inmates do have access to HIV testing services. They also have access to voluntary medical male circumcision. And at the end of the second quarter, we had about 3,890 males who have access to this service. We also provide, on a voluntarily basis, pre-exposure prophylaxis or PrEP. And at the end of the second quarter of 2023-24, we had enrolled in the PrEP program 3,702 inmates, of which 134 were females. We distribute male and female condoms, inclusive of lubricants, and inmates also have access to post-exposure prophylaxis, of which at the end of quarter 2, we had about 31 inmates who reported sexual assault, and one of those was a female. When we look at HIV treatment, you will find that 98% of all HIV positive inmates in our facilities are on antiretroviral treatment, and we also provide STI screening, diagnosis, and treatment. In terms of HIV care and support services, we do continuous screening for treatment and adherence counseling is provided. Inmates are encouraged to maintain and establish support groups, and treatment literacy is also provided to inmates. When you look at healthcare programs that we render, we do provide health promotion and disease prevention, which is provided by healthcare professionals, but also health promotion some of the facilities. We manage communicable and non-communicable diseases. Sexual and reproductive health services are available, including sanitary dignity, birth control, and referral for termination of pregnancy if there's a need. Antenatal and postnatal services, including prevention of infection to the baby, is also provided, and we take all precautions to ensure that pregnant females deliver these babies in the Department of Health facilities. But we are prepared for any emergencies should it happen. We can go to the next slide. Looking at the annual performance plan for 2023-2024, in the annual performance, we have 5 indicators, but for the purposes of this presentation, I will deal with only viral load suppression at 12 months. And at the end of the second quarter, we were at 97%. And for offender TB cure rate, we were at 95%. The other indicators that are in the annual performance plan relates to screening for diabetes, screening for hypertension, and prescription of therapeutic diets. Next slide. Those are the human resources that we have as a department. We do employ professional nurses, medical doctors, pharmacists, who are complemented by community service pharmacists, as well as sessional dentists and psychiatrists. Next slide. In terms of governance, we have established committees and fora to just ensure that we at all times improve on healthcare management. And these fora also assist to provide guidance at regional level and at management area level. And also it assists to coordinate processes just to make things to flow easily. And at the same time provides an opportunity for us to monitor compliance to guidelines. These governance structures are the pharmaceutical and therapeutics committees. We also have an infection prevention and control forum. And as a subcommittee of the IPC, we have a sanitary dignity committee. We also have a food service management forum. And all these structures biannually on a national level and monthly on a regional and management area level. Can you move? Slide. In terms of partnerships, we have a very good relationship with the Department of Health at all levels, because all the clinical guidelines that are utilized in the Department of Correctional Services are those of the Department of Health. That includes your ART guidelines, TB management, non-communicable diseases. This is done to just be the interface between the community and correctional facilities here. As inmates move in, we can standardize treatment. If we discharge them back to the community, treatment is standardized to ensure a continuum of care. We also have a very good relationship with UNODC in terms of capacity building of officials. We had training on harm reduction in July this year. The South African National AIDS Council, as the lead in all matters to HIV, TB, and STIs, also who work very closely with. We are currently busy with rights sensitization for officials in the Department of Correctional. Then we also have a number of non-government organizations that we work with. And in this instance, I would like to mention we have health partners and TB HIV care who played a critical role to assist the department with the implementation of PrEP and VMMC. Next slide. Those are just some of the quality improvement initiatives that we utilize. Monitoring we do for legislative prescripts, just to make sure that our facility in alignment with the ideal clinic model and that we comply to the Office of Health Standards requirements as well as regulations that governs hygiene services in our premises. We conduct also operational support visits to identify any service delivery gaps that might exist and so that we can facilitate quality improvement. Capacity building, obviously we can't go without that because we need to have a well-capacitated and capacitated workforce. We also invest a lot in conducting program reviews so that in doing that we can identify any missed opportunities, ensure that the clinical care that was rendered is of an acceptable standard. Next slide. In terms of future plans, it's worth mentioning that we have a lot of buy-in from principals for the implementation of harm reduction in our facilities, aligning to the NSP, and in particular, as a department, we are looking at opioid substitution. Hence, to that extent, we participated in a learning visit in May. We had training for healthcare professionals and to further benchmark at other two facilities in Tshwane, Victoria, with the aim to see what would be the best model for DCS to implement harm reduction and also to make sure that as we start within, we definitely have somewhere where we can confirm when in making our facilities. So this is work in progress, and we will definitely find ways to work around it. I thank you. We can move. Thank you. And just in conclusion, we are saying that as a department, through the implementation of mandates, improved governance, stakeholder collaboration, and quality initiative, we have made significant progress to reform healthcare services that are provided to Indians. Thank you very much for listening.
Thank you very much for this informative presentation, and I hope you can stay with us until the end of the session in case any of the questions will be addressed to you. Now we will move to the next speaker, and today we have Doreen. Doreen is the Director for Penal Reform International in Sub-Saharan Africa, and she has a long working experience on human rights advocacy in this region for the last 17 years. Thanks to Doreen for joining us, and please, the floor is yours.
Thank you, Leha.
Yes, my presentation is on HIV healthcare in prison, and I will focus on the statistics and the evidence we have on ground. And let's go into the slide, please. Can we move to the slide, please? No, the previous one. Previous. Sorry, go on. So, it is established that prisoners are key population, and we know very well from evidence on ground that closed institutions are actually vectors of disease in in sub-Saharan Africa. So if we are to realize the goal 3 of SDG, that means that the 12 million people behind bars every day cannot be ignored in HIV prevention strategies. We know that the average prison population rate in sub-Saharan Africa is currently one of the highest, standing at 1.92 million people, and it only comes second after America. Next slide, please. Those are the international standards. I will not repeat, but we know that despite the availability of a number of international instruments encouraging the improvement of prison healthcare, it still pretty much remains inferior compared. Yes, and women in prison are have more likelihood of having HIV or being HIV positive. The prevalence rate among women is pretty high in this region, and so it's important to use the intersectionality approach HIV prevention initiatives within the region. Next slide, please. According to UNAIDS, it's estimated that there are about 4.3% of the global prison population living with HIV, which means that for people in prison have a likelihood of 6 times more likely to live with HIV than the general population. The prevalence rate among the women is definitely higher than that of men, standing at 5% compared to 2% among male in prison. And sub-Saharan Africa, as the previous speakers mentioned, still has the highest prevalent HIV rate at approximately 15% compared to other regions. Next slide, please. And those are statistics from selected countries. We see that in Kenya, the national average is 6.3 prevalence. In prisons, we have 8.2. And female prisoners, again, have like 19% prevalence rates, and while male prisoners at 5.5. In Uganda, the national average is 5.8. The prison is 15. Women are 23 compared to 13% of men. So this is why we need to have targeted approaches. And the numbers go on. Zambia will have 38.9 among women compared to the national average of 11% and 27% among men. Next slide, please. Yes, those are some of the factors contributing to high prevalence rates. Violence, including sexual assault of vulnerable groups, including women and minorities. The lack of healthcare services, absence of prevention materials like condoms, lubricants, PrEP, all that is not in most of the sub-Saharan African countries. Poor nutrition, as we know that in some of the countries, people are selling sex for money or better services, while there's sex for food, for example, in some of the prisons. Next, please. Overcrowding, those are the overcrowding statistics for some of the countries compared to the capacity per country. For example, Uganda's prison capacity is 19,000 prisoners, and currently there are approximately
74,000 prisoners, which means that the prisons are extremely overcrowded, and so infectious diseases are hard to contain and manage. Kenya capacity is 34,000, but currently has over 61,000 prisoners. Again, it goes to show why prison is important to focus on in HIV prevention. Next slide, please. The other challenge is lack of political will to improve the prison budgets, as countries are grappling with low incomes, and the prison ends up suffering the most. And while the prison is receiving a lesser budget, the healthcare receives even a lesser budget. For example, the healthcare workers are really few in most of the countries. Zambia has around 70 healthcare workers. Malawi has 1 doctor covering 28 facilities. Uganda has recently recruited several healthcare workers, but again, we still see very few specialists in detention facilities. For example, there's only 1 psychiatrist, and specialist nurses are very few, affecting the quality of care. Kenya has 607 with 4 doctors and 151 nurses against that population. So which shows that really the healthcare service in prisons is still there. Next slide, please. Yeah, and we've seen over the years an increase in tough on crime policies and laws, which have increased the number of people entering prison. For example, in Uganda, we recently passed that law, the LGBT law. We are increasingly seeing tougher laws on drugs, which are increasing the number of prisoners and also pre-trial detainees. Stigma and discrimination and violence against prisoners and people after their release from prisons. The lack of continuity of care. In most of the countries in sub-Saharan Africa, there's no, it's hard for the prisoners to follow up treatment after their release, often leading to drug resistance, sometimes death, and poor health care. Reintegration services are not there in most of the prisons. Next slide, please. There's been progress, we need to acknowledge that. For example, HIV testing on entry takes place, but the frequency is still in question. The recruitment in most of the countries a few years ago, fewer healthcare workers than we've registered in recent years. For example, in Uganda now we have, because of the increase in healthcare support in prisons, there is a 98% patient enrollment for treatment and a 94% on separation status. There's a drop in infections, new infections in Uganda. In 2013, we had 5.3% new infections recorded in prisons, and currently it has dropped to about 3% in recent studies. So that's good, but more work needs to be done. Testing, for example, in Kenya is also carried out voluntarily, and medical workers are there in 57 of 75 prisons. With support again from UN, we've seen increased healthcare facilities within countries like Malawi, and I think that goes to show us the external support and how much it would improve service delivery. Next slide, please. Yeah, so I think if we are to realize the intended targets, national targets within the sub-Saharan African countries, we cannot ignore prisons and closed institutions. The healthcare budgets need to be revised upwards. There's a need for recruitment and training of personnel. Specialists need to be recruited into these correction facilities. We need to strengthen collaboration with external actors like UN agencies, NGOs, to complement the work of prison services and governments, especially given the meager resources that are allocated to prisons. And we need to embrace non-custodial alternatives to imprisonment. Next slide, please. Yes. So, despite the provisions of international instruments, we still know that prisons are pretty much left behind in this struggle to end HIV in Africa. Thank you.
Doreen, thank you very much for your presentation and thanks for keeping the time. And as you know, this year we always promote the meaningful engagement of civil society organizations and NGOs in prison health and HIV. Thank you very much. And last but not least, the ICASA host country. And today we have Commissioner Dr. Daka, who is the Chief Director for Health and HIV, and representing the Commissioner General for Zimbabwe Prison Service. Dr. Daka, the floor is yours.
Thank you very much, dear, for affording me this platform. Good morning, everyone.
Good morning.
Yes, it's already been said. My name is Evidence Gaka. I'm here to present on behalf of the Commissioner General. So, when I say I don't mean I. I'm going to present on the same topic, promoting criminal justice reform and prison health reform in Africa. It appears there are two separate topics: promoting criminal justice reform, promoting prison health reform. What we have decided is to focus on the angle of the criminal justice reform, which is supportive of prison health reform. Since this is a health conference, as already been alluded to already, prisons the world over, they have a very high disease burden compared to the general population. And as such, there is definite need for us to reform prison health. Transforming the criminal justice system across the continent is a matter of promoting structural development, human rights, social justice, and public health. Criminal justice reforms pave way for a more equitable and effective system that focuses on strengthening the correctional approach. Africa can champion reforms by addressing the state of prison infrastructure, policy frameworks, operations, and procedure, ensuring access to quality healthcare and necessary interventions to revolutionize the criminal justice system. Our objective today is to highlight all the measures to promote the criminal justice system and the prison. So I will start by giving an overview of the current state of the criminal justice system and prison health in Africa, the criminal justice system and prison health reforms. I will conclude and give the way forward. It is known fragile economies in most African governments fail to adequately fund criminal justice systems. There are problems of poor infrastructure, overcrowding, inadequate healthcare services, inadequate food and balanced diets, human rights violations, poor rehabilitation and reintegration, and delayed access to justice. African countries are making reforms to address such, and Zimbabwe is no exception. When it comes to infrastructural development, it is known that improving the physical infrastructure of prisons is crucial for decongesting correctional facilities. It will improve ventilation, it will improve lighting, which gives excellent health outcomes. Infrastructure development also helps to minimize the spread of communicable diseases. Currently, the government of Zimbabwe has approved the construction of 2 modern prisons. I'm sure you see 2 pictures of our modern prisons. That is Kami Maximum Security Prison, followed by Marondera Female Open Prison. Management of criminal justice systems are guided by international conventions, inclusive of the Nelson Mandela Rules, Bangkok Rules, Kampala Declaration, among others. The World Health Organization guidelines and protocols in all health and wellness matters. Zimbabwe Prisons and Correctional Service was rebranded in 2013 when we had our new constitution from being Zimbabwe Prison Service to Zimbabwe Prisons and Correctional Service. Clearly, the thrust there is on a correctional component. African countries are making reforms to address such. The Prisons and Correctional Service Act was gazetted some 4 months ago, and this is aligned to the new constitution of 2013. The Zimbabwe Prisons and Correctional Service is establishing mental health programs that offer counseling and psychosocial services in order to help address the mental health needs of inmates. We do have collaborating partners, the stakeholders with different jurisdictions and level of work together. They learn from each other's experiences and implement comprehensive reforms within the criminal justice system. ZPCS engages in international, continental, regional, and international collaboration, and our participation in ICPA and ICASA gives testimony to this. ZPCS also collaborates with World Health Organization, United Nations Office on Drug and Crime, and the Ministry of Health and Child Care, and other relevant stakeholders on health. We are also embracing technology. This includes implementing modern case management systems and the electronic filing and data systems. Zimbabwe adopted an integrated electronic case management system. There was also introduction of visual courts during the COVID-19 pandemic. The Ministry of Health is in the process of introducing the electronic health records. When it comes to recruitment, training, and development of personnel, this is periodic to fill in the gaps that are the result of attrition. There is a lot of emphasis on enhancing production. There is engagement in various production and business initiatives in an effort to promote self-sustenance and address nutritional health needs. Presently, Zimbabwe Prisons has got 2 prisons that are now self-sustaining. That is Mazoe Prison in National and Central, and Ani in Matabeleland North. As you can see in that picture, there is also a livestock production. All this in an effort to improve the nutritional status of our prisoners. There is a very high prevalence of communicable diseases in many African prisons. We do promote hygiene practices such as hand washing, proper waste management, providing vaccinations, and implementing measures to control the spread of diseases like HIV/AIDS, TB. Zimbabwe Prisons, through its health directorate and in collaboration with relevant stakeholders, is making efforts to address such health issues. The next picture shows the Commissioner General receiving his COVID-19 jab. All this in an effort to prevent. So when you've got such exemplary leaders, it means we get somewhere in all our efforts in fighting diseases within our institutions. Let me conclude by stating that challenges faced by prisoners, including overcrowding, inadequate health care, and violations of human rights, they demand immediate attention and action. By advocating for comprehensive reforms, Africa can create a criminal justice system that embodies fairness, compassion, and accountability. Together, we can build a more just and inclusive Africa, where the principles of justice, health, and humanity are upheld all the time. As a way forward, we feel that increasing budget allocations by government towards infrastructure development and healthcare services will take us far. Reviewing and adopting relevant legal frameworks, encouraging collaborations and networking, embracing the use of technology, continuous training and development of staff, intensifying production in correctional services through creativity, and upholding disease prevention and management programs. At this juncture, I would like to thank you all for your attention.
Dr. Gavin, thank you very much for your presentation. And also, I would like to take this opportunity to thank all the distinguished speakers. So please join me in another round of applause for the speakers. We are running over time, of course, but this is a very interesting presentation. So in case you have any burning questions, just let us know. We'll take one or two maximum, please. One, please. Do we have a mic? Yes, we have. Make it short, please. Yeah.
Good morning. Thank you. I will in the first place thank all the presenters for their wonderful presentation. Very effective. My question goes to Dr. M, Nigeria. I just want to know, apart from HIV testing services and treatment prevention that are provided as prevention services in Nigeria, what are the other prevention services that are being provided in those of those involved? Thank you.
Thank you very much. We'll take a second one here. Thank you.
Thank you very much. Two quick questions. I note that in the presentation, you really spoke about what is done for prison. What is done for prison staff themselves? And I wonder if there are programs for prison staff which are similar or maybe really a bit stronger than for the prisons. The second question is this thing about the when continuity, as you presented. Are there standards for that? Because it remains a problem. People get transferred, they get out of prison, and then the treatment will continue.
Last question, please. Here.
Yes.
Thank you.
Thank you very much. I just wanted to ask, I noticed in all that was mentioned, there was really no mention about educational interventions for those in prisons. I know, for example, in Nigeria we do it because I know some prisoners have had to take exams whilst in prison and have done quite well. And then also, I did not equally also hear about building skills of prisoners, knowing fully well that one day they're going to be out, except for those who have maybe life imprisonment sentences. I didn't hear those two come out quite prominent in any
Thank you. Thank you very much. And let's see who wants to start. Maybe Helen, you want to start, please?
Thank you for the question. Apart from the HTS and the arts, what other services are we providing? Provide PNTCT, we provide that, and we provide services for STIs, and we provide skill empowerment to the inmates. And speaking about the prison officials, in my country, there are included in the services provided. Like in my country, the people living with HIV are supported by the system, the prison system. May not be much, but they are recognized and they are supported. They are encouraged.
Thank you very much. Doreen, please.
Thank you. In most of the countries where we work, we know that studies on HIV include prison staff. But today, my presentation was pretty much focused on prisoners. But prison staff, in terms of assessing the population, they're included in all the studies and interventions. In terms of awareness raising on HIV prevention and safe relationships, unfortunately, that is very, done at a very minimal rate inside prisons. There is hardly any service providers that deliberately go in to create awareness about HIV prevention and care. But NGOs and some international organizations and church, I must recommend church, faith-based organizations are the most supportive in that regard. In terms of rehabilitation and reintegration, I touched on it. But again, if I look at the prison population, there's more rehabilitation services for the male than the female prisoners. So that is why also the effects are different for women and men living with HIV in prison. Thank you.
Thank you very much, Doreen. And Dr. Gata, please.
You're always saving the best for last. Thank you. As Zimbabwe Prisons and Correctional Service, we offer comprehensive healthcare services to prisoners, retirees, officers and their dependents, and also to the surrounding clinics. The setup is such that we have got staff clinics outside the main prison, and then inside we've got clinics that cater for the inmates. We also offer wellness programs in a structure here, where we cannot offer the services for our officers and inmates. We refer to government health facilities, and where the service is not being offered in government, we refer to where the services is being offered. I don't know if you allow me to pose a question to the House. I understand there are some countries that are offering condoms or are buying condoms to prisoners. What I'm mainly interested is in the results of the evaluation of the effectiveness of this intervention. Not necessarily in your country, but of any other country that you have known. Thank you.
Thank you very much. And maybe after this session, we can share some evaluation on this. If any of the participants have answer to Dr. Gata, please go ahead. Dr. Cedric, the last word before closing.
Thank you. This has been a very great panel. We've learned some very good insights. I think one of the biggest takeaways here is that we must continue to be the voice around funding and sustainability services around prisoners, specifically prevention, care, and treatment around HIV, STIs, and TB, as well as we must continue to think about reintegration and rehabilitation and skills empowerment services as well. And so I want to thank everyone, all the panelists, including on the line, South Africa. Thank you so much, Doreen, and thank you all for joining us today. Thank you, y'all.
Well, in closing, I want to share with you two things quickly. One, on the continuity of care, and as part of the standards, I didn't forget that, and yes, it's always there. Number one, the Nelson Mandela Rules, which is the United Nations Standard Minimum Rules for the treatment of prisoners. Rule number 24B is talking about ensuring continuity of care. In addition, all the UNODC and all other UN agencies like UNAIDS and WHO, when we talk about any of the topics like women's health, transgender people in prison, the comprehensive package of intervention, continuity of care is always an integral part of this technical briefing. Thank you very much once again, and I would like to tell you that UNODC stands ready to continue supporting countries in establishing and implementing evidence-based interventions for people in need. Thank you very much.